So we are live in 5, 4, 3, 2, 1. We are live now.
Good evening. Warm welcome to the first webinar on the soft skill of Indian Orthopaedic Association. At the outset, I would like to request our President, Professor Ramesh Sen, to give a welcome note to our members and to say something about this webinar. Over to you, sir.
Good evening, friends. This year, when we started, we had the theme that we should be getting the surgical skills as well as soft skills. What is meant by soft skill is now what we understand is that we are able to have not only the surgical technique with us, but the way we are with our patients. Incidentally, recently, we did an analysis of the problems with the hospitals, the complaints are there. Our grievance committee made a decision. What we found it out, what was the most common reason for complaints was inadequate, poor communication in 49% of the complaints. Like doctor did not listen to me, doctor did not attend me, I was made to wait for a longer time, I was ignored. Delayed treatment was 28% and complications were 23%. So out of everything, it is the communication and a behavior which was in 49%. So that is the importance. It is not surgical skills. These are the soft skills where we need to improve. So I'm very happy that we have this topic as our starting topic, and I have all the best wishes. And we have the best people here for the subject also. And I think we are all likely to gain a lot out of it. All my best wishes. Thank you, Dhiren. Please.
Yeah, thank you, sir. Naveen, we would also like to hear something from you also.
Okay. This is a very good topic selected by our committee, and Dr. Ram Chaddha is chairing this committee, and he has a lot of material for communication, and Dr. Dhiren Bhai is facilitating all this. So we welcome on behalf of IO office to all the members, and there will be a complete series one by one. So wait till the complete series is over, and it is recorded in the IO TV and Ortho TV, so you can listen it anytime. So please proceed, Dhiren Bhai. Thank you very much. And thanks to all the faculty.
Yeah, thank you, Sensor, and thank you, Dr. Naveen, for giving us a brief idea about why this topic. First of all, I am Dhiren Ganjwala. I am from Ahmedabad. I am pediatric orthopedic surgeon, and I am thankful to leaders of Indian Orthopaedic Association for giving me the responsibility for hosting this webinar. So, sir rightly said that in 49% of the patient, they are really unhappy with the patient's communication. And that is one of the reasons why we are conducting this webinar. We all know that communication with our patients and family member is the cornerstone of our medical practice. We communicate with them every day, and approximately it's 80 to 90% of our OPD is basically based on the communication. But the sad thing is that most of us have not received any systematic training for this communication. And how we learn? Usually we learn by observing our seniors and by trial and error. So basically our training for the communication is not adequate. The second thing is effective communication is very useful for building trust and confidence about us in our patients. And that is very important because that improves the compliance of our patient for our treatment. And when they are compliant, definitely the outcome of treatment is much better. What is really we are looking from this webinar is one of the major problem in our practice or in current days is litigations. And we all believe that litigations can be avoided to great extent by better communication. And in addition, it reduces the stress and prevent burnout in a long run. So with that short introduction about the topic, now I would like to introduce our expert. This webinar, we are really fortunate that we have 3 experts about this topic, about the soft skill and about the communication with the patient. The first is Dr. Ram Chaddha. He's a practicing spine surgeon in Mumbai, and he's a president-elect of Indian Orthopaedic Association. The second expert is Ajith Kumar, who is a trauma and joint replacement surgeon in Bangalore at Tejaswini Hospital. He is also a past president of Karnataka Orthopaedic Association. And the third one is Dr. Vikas Jain, who is a hand surgeon practicing in Vapi, Gujarat. He is an immediate past president of Gujarat Orthopaedic Association. And more important, he is the strong proponent of soft skill training in medical training. He is like believing that if we start inculcating this training or this skill to the resident level, then definitely we can make a big difference. And about this webinar, this is not going to be any lectures. It's going to be interaction. If you have any questions related to this, already we have shared a WhatsApp link. You can send your questions or your comments to Dr. Naveen Thakkar, and we will also like to take that questions in the discussion. So with that, we start with the first question. And the first question is very basic question. And I would like to ask Dr. Ram Chaddha, how much time do you give to your patient on an average?
Good evening, everybody. Thank you all for being here. Time is the most critical part of soft skills and patient handling. The time that you give to a patient in active listening is the most important. I practice mainly neck and low back pain. On an average, I see my patients for 20 minutes the first time that I see them. This 20 can at times become 25, and a follow-up visit, the 20 may become 15. So on an average, I see about 3 patients in an hour, and in a day, I would see patients for 4 to 6 hours. That's how I work in my clinic.
Okay, the same question we would also like to know about Ajith Kumar. You are practicing mainly a trauma patients. So do you give the same amount of time or you give less time to your patient?
Good evening, everybody. Thank you, IOA and Dr. Dhiren, for having me on this panel. That's a very pertinent question. And like Dr. Chaddha said, it's very important that we invest time in our patients and make them feel comfortable and carry on with our interactions. Yes, unfortunately, my practice being in mainly trauma and some of general orthopedics, I don't think I spend 15-20 minutes with my patients. Most of the time, trauma patients, it doesn't take that long to analyze or assess. But of course, some of the times there is a long drawn history from, multiple centers they would have visited or multiple surgeries they would have undergone. Those patients definitely need much more in-depth discussions, and that takes time. So yes, I mean, we slot patients at 15-minute intervals, but by and large, we finish much quicker than that because most of the time you're basically evaluating the of course, the discussion in the history, then of course whether the fracture is united, whether the range of movements are good, and then you make the patient walk maybe and have a look at the X-ray. So all that as you get more and more experience, I guess you can cut down on the time, but early in your practice, I think it makes sense. It's that you spend about 15 to 20 minutes with each individual patient.
Okay, like I would like to ask Dr. Chaddha that you said that you give on an average 20 minutes to your patient. Now, I'm sure that most of your colleagues also must have commented that this effective communication requires a lot of time and we don't have in our busy practice, adequate time for communication. So how do you respond to such comment?
I have a very simple one-line answer. I have believed in doing justice to few rather than injustice to many.
Right. Okay. So that's in a nutshell, you said that like it's better to focus or to have a quality practice rather than a quantity practice.
Yes, sir.
Yes, Ajit, would you like to say, because I am sure that there are a lot of people who come to you as observer, and if you tell them about developing effective communication, they have the same thing, that in a busy practice, we don't have time. So what is your comment on that?
What I feel is investing time in patients, I think it is akin to investing in the stock market. It is not a short-term investment, it's a long-term investment. And in the long run, it is definitely going to bear fruit because word will spread that you are interested in the care of the patient rather than in the the short-term benefits that one looks at it. So I think yes, we do. I mean, when you start practice or when you're in a busy practice, it appears that you don't have the time. But trust me, if you spend time, it becomes second nature as you get along in your practice, as you get along in your years, it becomes second practice. And there are so many ways you can circumvent certain inappropriate discussions or whatever, and get through to the real information that you need by actually you make the patient feel that you're actually listening to them. And also what I tell my juniors is that it is very important that you give your ear to the patient, and doesn't matter if a couple of patients take more than the 5 or 10 minutes that you do allocate to them. But in the long run, that confidence and that the trust that the patients develop will come back to you, and it will enhance your stature and reputation.
Okay, thank you. Now, Vikas bhai, I would like to ask you, because you are like having a lot of stories and you are very fond of telling the stories. So we would like to know from you, can you give us a very good example or an incident which has taken place and that has made a big difference in your practice? Something like effective communication, how it can build a reputation, how can it build a trust? So can you share one of your example or stories?
It has so recently happened, that I had a young middle-aged female patient who had come to me with the complaint of low backache with pain in her right hip and the right groin and thigh area. As usual, when I have been seeing patients, we see the gait of the patient, we see to it how the patient comes and walks into your OPD. And then it comes is that you have to spend time, as rightly said by Dr. Chaddha and Dr. Ajith, you have to take proper history taking, you have to have a proper eye contact. What happens is here in this patient, after taking proper history and after having done examination, I could make out that the patient had early stage of AVN, while this similar patient was previously treated for low backache in the previous OPDs. So I'll just shortly tell about the comment that the patient had given after proper diligence that was followed. That sir, आपसे पहले मैं जहां भी गई वहां पे मुझे 5 मिनट में मेरी हिस्ट्री लेने के बाद मुझे बैकेक के लिए दवाई लिख के भेज दिया, किसी ने मुझे लेटा के एग्जामिन भी नहीं किया कि मुझे ये. So these are few things which are happening in an overburdened situations, where many times when the patients come to your OPD and just by taking initial few lines of the history, you come to a tentative diagnosis. Okay, this is what it is. The impression that the patient carries is very important. You may land up into wrong diagnosis, and also that the patient has come to you with certain expectations. It is imperative for the doctors to understand the expectations of the patient and relatives. That is why you have to invest that time into the patient. So this was a very small example that happened as far as giving time to the patient and then trying to understand sequentially what was the diagnosis. It has happened many times with many patients. So this was one small example that happened.
Okay, good. So basically, like the proper examination is one of the thing, and most of the time, like now we have a MRI, And Dr. Chaddha, I would like to know, because you are practicing in Mumbai, where most of the patients are coming for the second or third consultation, and they must be having MRIs or sometimes 2 or 3 MRIs with them. So in that case, how would you look at the practice? Like, do you continue to follow the same thing, like focusing on the communication first, or you would like to straightway jump to MRI?
Sir, I love your question because I am looking at this a little bit differently. Sir, if a patient is coming to you with multiple MRIs and is still coming to you, means he is very unhappy. In fact, this patient needs for you to go through that proper ritual of history, followed by detailed examination, followed by plain X-rays, followed by old MRI, followed by new MRI. And not exactly the opposite, which is probably the reason why he has reached you. So that is my first comment on this when somebody comes with those bag loads of MRI. Another thing which I would like to comment. So there are 3 words in English which are interchangeably used: hope, belief, and trust. So they mean very different to me as regards my patient. And I'm making it very simple to you how I look at it. Hope is what the patient comes to me with because he or she is unhappy. Belief they develop in me if they believe that I have delivered the goods with similar situations in the past. And trust is finally when they decide that they are choosing me to deliver the goods to them. So there are 3 different words. When a patient reaches you, they all come with hope. Getting them to believe in you is in your hands. And if that belief with truth and transparency can be converted to trust, then the responsibility is totally yours.
Yes.
So this can only happen if you go through this same ritual: history, examination, plain radiology, and advanced radiology. I'm talking specifically of spine. I'm sure that this has to be extrapolated or modified to other subspecialties, but sir, the rule is the same. So this is how I go about it. I've learned it the very hard way, but I still follow it, sir.
Okay, very good. So in addition to that, I would like to know from you, like say you are practicing the communication skill, or your communication skill is excellent. Have some patient given a positive comment to you or to your staff about your communication skill?
Sir, I have my entire group which has been aware of the way I respond to either a positive or a negative remark, and our response is thank you very much. We are neither sharing our glee nor our distress at a remark, and they have seen it on my face through the years, and they all respond to it very similarly, because there will be good days and there will be bad days.
Okay.
So we appreciate everybody's inputs and we are grateful for it.
Ajith, Dr. Ajith, I would like to ask you a slightly different question. That we talked about a good communication, but time and again we see either we or our colleagues having a poor communication skill, and that has resulted into some problem. And you are like, you were the president of Karnataka Orthopaedic Association, so lot of problems must have come to you from different centers. So can you share some of the example with us about a bad example of communication, or you think that this could have been avoided by proper communication?
Oh, certainly, sir. I think most of the time, whether we have imbibed it from our seniors, I'm not sure, but most of the time the complaint that has been was that we've been very abrupt or we have been downright rude. These were some of the complaints that we got. And I think that's what finally, even when it goes to the consumer courts or wherever, This is the unhappiness that goes out of this thing. So yes, we had a couple of scenarios where patients had come for a second opinion, or they had complained to the association, basically because not always the things go right. They don't always go as you expect. There will be some complications, some issues. But if you don't address it properly, or if you hide it, many a times the doctors were found to be very rude. So this was the most common complaint that we received, sir. And occasionally, probably it even happens in a busy practice, even with us, that you are a little abrupt. You may answer 2-3 times and then you may say something, but it's the last sentence that remains in the patient's mind. And that's what he carries when he walks out of the clinic. And I think that is very crucial that, like Dr. Chaddha said, even if it's a bad comment, thank you, or I accept what you say. That should be the comment, I think.
Thank you. Vikas bhai, from your own personal practice or experience, can you share some incident where now you think that if you have communicated differently, that would had probably make a difference to the result or the outcome of the treatment?
Yeah, so in the earlier years, when we were out from the residency and we were in the earlier years of our orthopedic practice, the entire attitude of the communication that we had in the residency was very different than what it happens in a private practice, actually, if you see. So it so happened that you come to a private practice and it is not possible that you immediately would transform yourself into a stage where you do a proper communication that is happening. And so in the earlier years, it used to happen that the time that was given to the patient was very less. Probably I would not communicate properly as expectation, because it's ultimately the patient who comes to you with certain expectations. So it has happened at times that I would directly come to a diagnosis, okay, chalo, aapko ye takleef hai, aap ek kaam karo, ye kara lo, ye kara lo, ye kara lo. And then it was at that time that the patient would go out, and maybe at times few patients have spoken that sir ko time hi nahi hai, sir जो मैं को क्वेश्चंस पूछने थे वो क्वेश्चंस मैं सर को नहीं पूछ पाई या पूछ पाया. तो ये सब फीडबैक जब आने लगे, that is the time subsequently that I realized that you need to understand the need of the patient. The patient who's sitting outside your OPD for a big time of say 15-20 minutes, there's a waiting time. वो घर से जब आता है तो वो मेंटली प्रिपेयर होके आता है कि मैं जब डॉक्टर की ऑफिस में जाऊंगा तो मैं ये क्वेश्चन पूछूंगा. Most of the times it is not only trauma. When you're sitting in an OPD, even for a general orthopedic surgeon, you have got non-trauma cold cases, and that is where that pain, limp, inability to walk, inability to do certain activities, or maybe some history of trauma. ये सब चीजें ओवर द टाइम, ओवर द एक्सपीरियंस समझ में आया इन लास्ट 10 years कि ये बहुत इंपॉर्टेंट है कि अगर आपको लाइफ में आगे सक्सेसफुल होना है, आप कितने भी अच्छे सर्जन हैं, लेकिन जब तक पेशेंट के साथ जो कम्युनिकेशन है वो कम्युनिकेशन अच्छा नहीं हो, पेशेंट कमेंट करता है. मेरे खुद का एक्सपीरियंस है ऑफ माय ओन मदर, व्हेन आई हैड गॉन टू अ डिफरेंट डॉक्टर, नॉन ऑर्थोपेडिक डॉक्टर, फॉर हर एलिमेंट्स. She had gone to a doctor where the doctor had seen her for just 2 minutes and given her medicine. And मुझे घर आके बोला मैं अगली बार इस डॉक्टर के पास नहीं जाऊंगी. मेरे को जो बात करनी थी, जो सुनना था, जो मुझे बताना था, वो नहीं बोल पाए. And the other doctor definitely treated her well. So irrespective that she was given the same medication, she responded better to the doctor who had given her time and had communicated well with her. So ये सब experiences हैं. This has come. The only reason why I'm telling you is that her resident, her young orthopedic surgeons जो अभी आ रहे हैं, सबके लिए ये जरूरी है कि हमारे जो एक्सपीरियंस है सर के, आपके एक्सपीरियंस है, अजीत सर के एक्सपीरियंस, राम चड्ढा सर के एक्सपीरियंस, इवन जितने भी है, इन सब एक्सपीरियंस को सीख के एटलीस्ट दे मेक अ बेटर एंड गुड कम होलिस्टिक ऑर्थोपेडिक सर्जन, सक्सेसफुल, बिकॉज रमेश सेन सर ने सही बोला, सक्सेस हैज टू हैव अ कॉम्बिनेशन ऑफ सर्जिकल स्किल एंड सॉफ्ट स्किल। तो ये चीजें बहुत इंपॉर्टेंट है। इतने ज्यादा एग्जांपल्स एक के बाद एक हम दे सकते हैं, पेशेंट गोज अनसेटिस्फाइड एंड दैट हैज रिजल्टेड, मेरे साथ खुद हुआ है कि पेशेंट वाज अब्यूजिव, because of certain problems, and all you think is you cannot abuse them back, but it has resulted into a disastrous situation and you had to handle that bad situation. So subsequently we'll discuss about all that, but problems hoti hain in case of poor communication.
Okay, good. Just a quick by question. All of you are holding a big post in the association. So does it affect any way in your day-to-day practice? This is not related to communication, but it's like the holding a post at association, because you get a lot of call, particularly when some major issue is going on. So how do you manage that?
Ramesh Sen sir, Naveen sir also can answer.
Yeah, exactly. So yes, sir.
Yes, naturally the problems in communications are not only restricted to our patients, they are restricted in our day-to-day life also. And that is expected, that if we are open to listen to what the other person is saying, if we are able to appreciate the concern which he has got, I think that itself starts reassuring the person that I have been listened to. And there this positivity comes in the communication, because the first indicator of that satisfaction starts coming up. Obviously, many things may be solved, many things may be difficult to solve, may not be able to solve. But again, coming back to the same thing, listening, as Dr. Ram also said, makes the first change in the person who is concerned also, who has got a complaint also. So I feel solution may come, may not come. But once you have been able to understand why the other person has got a problem or what's the issue, I think the success comes in that management also. So it is listening which becomes a very important part in this communication.
Okay, sir, just the question which I was asking all of you, but particularly you, like, say, you must be getting a lot of disturbances from the colleagues, because now you are the president of Indian Orthopaedic Association, and a lot of people wants to reach you. So you are in in the consultation is going on, and then the phone rings. You see that it's a vice president of Indian Orthopaedic Association is calling you. So do you receive the call at that particular time, or you reject the call and then you call later on?
Incidentally, in my OPDs, I usually do not take any calls, because, if you are with the patient at that stage and if you get disturbances by a call, it makes a big nuisance to the patient also. He knows that this person doesn't have a time for me. And when, as we have already been saying, that if I am with the patient, I am with the patient wholeheartedly. So in my practice, I don't take any calls during my OPD hours at that time. My OPD hours are not very long. They are just for 3 hours. But in these 3 hours, I usually don't take any calls.
Okay. Like, see, once I heard, yeah,
here we have to use the technology.
How? Which technology?
You just give a message. There are ready-made messages. I will call you later or something. That message goes. Once you finish up your work, then you devote your work for the office, whatever work is there for the communication.
Okay, good.
So
yes.
Communications are important. You cannot just cut the call. You just give him a message that I will call you back later.
Okay, good. So, like, I made the same point to one younger colleague, and he said that, Dhiren, you have reached at a level like now you are 55 plus and you can afford to do all these things. But I am just starting my practice and I can't reject a call from a colleague or like someone who is referring me a patient. So what will be your answer, Dr. Ram? How would you respond to this comment by a younger colleague?
Sir, I would respect the way he thinks. However, I would try to tell him that you are as good as you think you are. What I mean by this is, sir, if he is going to try and connect to everybody, then 24 hours in a day are too less. So he has to prioritize and he has to do justice to a few, if not fewer, as I'm saying, rather than try to put his hands everywhere. I do understand that he would like to communicate with the referring doctors, with his colleagues, with the patient's family or the patient's relatives. But sir, please understand that one man can do only one thing at one time. So he can choose to keep his phone switched off in the clinic and not take a call. When that same patient has been seen and has been given 100%, he will realize when he's trying to reach the doctor that he's not being able to reach because somebody else in as much, if not more pain is in front of that doctor at that time. And this has to be done by choice. If for 4 hours, Dr. Jain does not attend calls, he has seen 20 patients. Those 20 patients go home realizing that Dr. Jain has not attended calls. And if they were to try to reach him, they should also get that message directly or indirectly that the calls were not received for the same reason. Same thing will happen with your colleagues or your other subspecialty sort of colleagues or partners in your practice who would probably respect you for your time, sir. So it's the way you are. You want to be available for everybody, then you cannot do 100% justice to the person sitting in front of you. So somewhere you have to say enough, because how much ever, as Dr. Naveen Bhai says, that digitalization and all this newer technologies are going to aid, but then digitalization is also causing a lot of distraction and dementia in the long run. So that distraction and destruction is actually doing more harm than good. So we have to take a call.
Okay, thank you. So a message is very clear that when we are in front of patients, it's always better to have a full concentration with them in the discussion which is going on, whether it's listening or whether what we are conveying. But if we try to divert, then probably that link which has been created in communication will break. Okay, so with that clear message, after understanding the importance of communication, we go to now a slightly more integrity of the technique of communication. And for that, I ask the first question to Dr. Vikas Bhai, that we always feel that it's very important to have a rapport building with the patient, because patients are coming to us, they are not known to us, and they are not familiar with us. And in the first few minutes, we really need to have some technique so that they feel at ease. And then they become more friendly with us. Friendly in the way, like say, more comfortable with us. So what do you do for that rapport building important point?
Yes. Thank you, sir. If to start with technically, one should understand that there are 3 types of communications. When we refer to communication, communication is nothing but it is an information exchange that happens between 2 humans. One should not forget that here, when we talk in terms of communication, it is a human factor and a human to human communication, right? That means there are so many tangible and intangible factors which play a role in a communication. So you have a verbal communication, you have a non-verbal communication, you have a paraverbal communication. Setting aside this technicality, let me tell you very simply that not sitting with a mobile, sitting in an office, you should be yourself presentable. You should be smiling. You should be well prepared to see your OPD patients. If you are tired, you are frustrated, you are stressed, that immediately the patient is going to pick up. Right? Sir, આજે તમે બહુ થાકેલા છો. આજે તમે fresh નથી લાગતા, શું વાત છે, તમે હસતા નથી, smile નથી. This has happened. They pick up, right? So important is this. As soon as you do this and the patient is in front of you, he understands you are smiling, you are receptive. उसके लिए first connect वहीं establish हो जाता है. उसके बाद then you start with your questions. It may not be pertaining to anything to do with medicine, anything to do with orthopedics. If you know the patient, you can just make 2 or 3 remarks about how he has traveled, कैसे वो आया है, did he have to wait long outside. ये कुछ चीजें होती हैं, वो immediately second level का connect create करता है, right? Eye to eye contact होना जरूरी है. Language barrier नहीं होना चाहिए. So because if the patient is Gujarati, I talk in Gujarati. If it's in Hindi, we talk in Hindi. Sir also does that. Marathi है तो Marathi, Hindi है तो Hindi, Gujarati है तो Gujarati. So language barrier नहीं होना चाहिए. इन सब चीजों को उसके बाद you let the patient speak what he wants to speak. As Ramesh Sen sir rightly said, active listening. We have to be listening to what the patient wants to say. वो prepare होके आया है, आपके सामने वो हर चीज प्रिपेयर करके आया है कि मैं वहां जाऊंगा तो ये बोलूंगा, हम उसे काट नहीं सकते. ठीक है रहने दो, वो हम बाद में देखेंगे, अभी पहले ये बताओ तुम क्या एक्सरे लेके आओ, क्या एमआरआई लेके आओ. हमारी आदत है पहले हम उसका एक्सरे एमआरआई सब हाथ में पकड़ लेते हैं. दैट्स रॉन्ग. उसे बोलने दो, राइट? उसके बाद जब अपने को जो हमारे क्वेश्चंस हैं हिस्ट्री टेकिंग वो हम ले लेते हैं, बट पेशेंट और डॉक्टर के बीच का जो कनेक्ट है, once that connect is well established, the patient is far more relaxed. So in the initial stages, as you say, in an OPD practice, you need to establish the verbal, non-verbal and the paraverbal communications between you and the patient. And of course, there are barriers. You should understand those challenges and barriers, and you should be in a position to correct that instantaneously. That's the skill. And that is why we are here. In order to teach those skills. Communication आता है, लेकिन communication में challenges आते हैं, barriers आते हैं, problems आती है. उसकी वजह से क्या क्या होता है? That's what we want to give back to the young orthopedic surgeons.
Good. Thank you, sir. Dr. Ajith,
Yes.
you are in a trauma practice and a lot of patients come to you with fracture, which is a very different scenario than that of a consultation, like where they have a spine problem or a neck pain or a knee pain. So how your strategy is different than the routine consultation? Because the patient is in real pain and you have to take care of that. And then at that point, how do you try to develop rapport with them?
Okay, I think basically if you're looking at an acute trauma scenario, like in an ER or in the ICU, if at all, that's a slightly different scenario. I mean, the patient will be very agitated, very, in fact, maybe, totally in shock as to his status. I mean, whether he'll be very apprehensive, whether he'll be able to ever walk, whether he'll be able to ever do his normal jobs. So these sort of anxieties make it much more difficult to handle that situation there. So I think basically, again, he may not be even in a position to give a proper history there. So try to reassure him, try to calm him down. You have to give him the analgesics and all that that routinely goes on. But more important, get the family involved in the discussion or any standard, the person who brought him there. Get the history, get them, reassure them, make sure everything is okay. Tell them that, we will make sure that he gets the best attention and the best sort of treatment, not to worry. And it's just a fracture which will mend with proper care and in due course, not to worry, that sort of thing. But even a fracture patient in a second or third consult, if he comes to you from elsewhere, there also you have to develop a rapport. And like what has been told by Dr. Vikas, it's the same thing. First and foremost, I think how you present yourself to the patient and family. You greet them, you smile at them, you make them comfortable, you make them sit down, relax, and in a very sort of a relaxed manner, you sort of start interaction. And more important is, like Dr. Vikas said, let the patient narrate what they want to. Let them get going with the history and try and not interrupt them too much. So these are the things that generally one does to gain the confidence at the first consult. The acute scenario is a little different. They will be very agitated and it takes a little time. But of course, the family and the relatives also will be anxious. So it takes the whole group to be taken into consideration. That's a different scenario. But I think in the clinic, many a times I've been in a situation where patient asks, "आप वही डॉक्टर हैं? आप तो इतना बाल पूरे बिगड़ गए आपके, क्या बात है?" You know, they may forget. They may have seen you years ago. They may have forgotten. So you have to introduce yourself. Say, "Good afternoon, I'm so and so." Or best is to have your white coat with your name on it. Even today, a patient, because I was with a mask, asked me, "Are you the same Ajith?" You know, so it's like that. So you will have to introduce yourself, make them comfortable, make them understand that, you know, you have their interest in hand, and then get going with the proper detailed history and the examination.
Okay, good. Thank you. Vikas bhai, you emphasize, and I'm sure Dr. Ramesh also emphasize about active listening. Now, I would like to know from you, what do we understand by active listening?
Sir, active listening.
Because listening is listening. So what is active listening?
So active listening basically means exactly what we have been discussing, you know, where you completely concentrate into what the opposite person is wanting to say to you, trying to understand his verbal and non-verbal communication, you know. So what he trying to tell you is, you are trying to listen, but you're also observing him. You're not interrupting him, right? Otherwise, what happens is, again, as it has been discussed, you look into your mobile, you are trying to work on a share market, or you look into the, it has happened in an international level where doctors are wanting to make electronic medical records, EMR. So it's a big discussion that's happening there. So when a patient is sitting in front of an international doctor, suppose, and they are making an EMR, what they do is they look into the computer and try to make the notes. Even that is not considered to be active listening, right? Active listening, your eye-to-eye contact is there. You are actively trying to listen to what the patient is saying. You are trying to connect, because there's a human connect that happens when the patient is sitting in front of a doctor. The patient realizes very comfortably कि ये doctor मेरी बात सुन रहा है कि नहीं सुन रहा है. So that is, these are all small components of active listening, which again we have been discussing in the previous two sessions. And as Dr. Ramesh and I have said, you know, challenges of not having active listening are definitely great. You know, you might end up into telling patients something which is not relevant because you have not listened to what. You might end up into doing a wrong diagnosis. You might also create uncomfortable situation for the patients at time. Now that is the part that can happen, you know, when you are not properly into that right stride of having a proper communication with your patient.
Okay, thank you. One of the major problem which I have faced is like what we call it a curse of knowledge. We are experts. We know the medical things and we talk that day in, day out. Now the problem is like when we are trying to explain the medical diagnosis to the patient, for them it's completely new thing. Like when we say spondylosis, for them it's completely new thing. So Dr. Chaddha, I would like to know from you, how do you explain the medical condition or medical diagnosis to the patient? So there are different ways. One is by telling, the other is by showing some pictures, the third is by showing them the model, and on that you explain them about the diagnosis. So what are your tricks for explaining the diagnosis to the patient?
Thank you, sir. Hello.
You are connected, Dr. Ram.
I can't see anything. One second.
Oh, suddenly it has gone.
Yeah, I'm back. Sorry. Sir, in response to this, I would just walk you through a few things which you have to just visualize. Sir, I have a clinic where when the patient enters, he enters with 1 or 2 caregivers. I am sitting on an examination chair where I am normally seated with a table. There are 2 seats for 2 people to sit, and there is an examination couch which is at a higher level. Hear me out, because this is now going to tell you who stays where and the level of importance. Sir, of the 3 people who walked into your clinic, you know that 1 is a patient, the other 2 are caregivers. That 1 person needs to be seated on that couch at a higher level from the very beginning and remains there till he is the center of discussion. Am I clear about what I'm saying? He is the center of discussion till the stage of diagnosis. He is the most important person there. At that time, an over talkative, over inquisitive caregiver is not. May I repeat what I've said? He is still the most important seated there. My attention is to him all the time. This is the first thing, sir. Whatever the caregivers may be saying, that patient is my patient and I'm treating him. So that's the first part of it. How do I reassure and connect him and convey this to him? Sir, I am also seated at the low level, at the level of his 2 relatives when he's speaking, and we are actively listening. Again, what I say goes in exactly the verbal and non-verbal modes as mentioned by Vikas Bhai, which I look at as 7% verbal, the words I use. Same thing, 7% verbal from their side, the words that the patient uses. 38% vocal, the tone. So there are a lot of people who may have a lot of pain, but it will not show. And there are people who hardly have pain and will have crocodile tears. So that all comes in tonality of voice. And 55% is visual or body language. It works in both the directions, sir. This is called Mehrabian's rules of communication. It is 7-38-55. We convey that way, they convey to us that way, which means what is the most important for both? 55% is the body language. So keep him there, keep him there. How do you establish your connect with that person? So there is a period where you will go in and examine him physically with the curtain drawn, with a chaperone if she is a lady, or without a chaperone if he belongs to your same sex. Am I correct? That is the time you ask a few personal questions where he conveys to you only you. Cigarette peete ho kya? Sharab peete ho kya? These are things which are not asked in front of the rest of the patients. He has conveyed it to him. He is happy that he has told you, but he has not told you in front of the rest of the family. That is a bond you establish there. Then you come back. Once his diagnosis is established, he then moves to the level with you, because otherwise you will have to stand up to his level. If he is capable of coming to your level, bring him to that level and speak. If he is a patient who cannot be moved, has to be kept there, stand up and speak to him at his level. I use a lot of bone models. I use a lot of structure because I have the advantage that I'm limited to cervical spine, lumbar spine. I can do a lot of things with models to show them. I use very simple language. In spine, sir, only 3 things can be done. नस को रिहा कर सकते हैं, decompression. हड्डी को फ्यूज कर सकते हैं, अनस्टेबल सिचुएशन को स्टेबल कर सकते हैं, स्टेबलाइजेशन. एंड रेयरली डिस्क को रिप्लेस कर सकते हैं, जॉइंट रिप्लेसमेंट. These are the 3 things. The other thing we do is deformity, which is a totally different ball game. So I am very safe. I have to just speak 4 things and nothing beyond that. I commonly have to face a situation where I am told कि मेरे गर्दन में गैप है या बैक में गैप है. My answer is मेरे में भी गैप है और गैप से मूवमेंट होता है. All of them say they have spondylosis. I tell them I also have spondylosis. It is like graying of the hair. So it's very simple. There is nothing. There is no rocket science. But this is the way. It's only when you start discussing treatment that you bring yourself to the level of the patient. Till that time, the patient is leading the discussion. And let him have the importance. Sir, we don't realize at times that the caregiver may be the cause of the problem. It is our duty to give the importance to that patient for that 20 minutes. And that's all that matters. That's all that I have to say.
Okay, thank you. Then another problem is time and again in Western literature, they say about shared decision making, which is, I think, very new to us because we all believe that, and patients also time and again says that, doctor, you are God, doctor, you are God. And then we start believing at some point that we know everything and we know what is better for that particular patient. And then whatever we feel that XYZ treatment is good for or the best for that patient, we say that this is the treatment you need to do. Instead of that, there is another approach which is called a shared decision making. Vikas, would you like to say something about this? And do you use in your practice?
Yes. So, as we are now evolving into a very dynamic healthcare environment, where the patients are also well aware and they are over aware because they overread, right? It is very important that we as doctors should understand what is SDM, as we call as shared decision makings. Now, shared decision making is something which I had talked about in Code of Ethics when I was there in Bangalore, and this is a part of even Code of Ethics. It is very important that we give autonomy to the patient. It is not the doctors who can decide for the patient. It is the patient and the patient's relatives who decide as to what they want. The doctors, when they are there, they are supposed to come to a diagnosis. They should be in a colloquial language, explain the patient about whatever disease or the suffering that the patient has. It could be acute, it could be chronic, as Sir rightly said, degenerative disorders. So where you tell them that this is what it is, then you have to give all the possible choice. The choice is, it could be non-operative, it could be operative, it could be conservative, it could be doing only physiotherapy. So it depends on the entire range of choice that you give to the patient, right? Let the patient, so once that is known as number 1 stage, which is known as the choice talk. So when you have SDM, there are 3 talks. One is known as the choice talk. After you have done the choice talk comes the option talk. That is when the patient or the caregivers साथ में जो हैं वो लोग आपस में discuss कर ले, patient अपने आप सब चीज समझ के, then they come out with the option, and that is should culminate into what is known as the decision talking. So that decision of what they want is known as shared decision making. After this shared decision making process, it's a linear process. Understand? It's a linear fluid process, as we call. एक के बाद दूसरा, दूसरे के बाद तीसरा. Decision making is last. इन सब चीजों को हम कंसेंट फॉर्म में जब डालते हैं उसको बोलते हैं informed consent. That detailed informed consent comes from shared decision making. That means what you have done is आपने जो प्रोसेस वर्बली कम्युनिकेट करके एनेबल किया, उस पूरे प्रोसेस को आप रिटन फॉर्मेट में फॉर योर रिकॉर्ड्स उसको वापस डालते हैं, which is in true meaning known as informed consent. So this is shared decision making, which is very important now because we are in the era of litigations.
Okay, thank you. Another challenge which time and again we all face is when we have to convey a poor prognosis or a poor diagnosis, which is not good, then sometimes we also feel very sad about telling the diagnosis, particularly like when I have a Duchenne's muscular dystrophy child, where we really can't do much and we know that this child is going to deteriorate with time. So Dr. Chaddha, I am sure that you must also be getting a patient who has come to you for a back pain. You get the investigation and the investigation says that this is metastasis, possibility of metastasis. So you really know that metastasis is not a good diagnosis. So at that point, how do you convey that to your patient?
Sir, in fact, most of my patients are backache patients and they are unhappy people, and I'm trying to make them less unhappy. So my opening line when I begin my shared decision making is usually the same. And the line is, do you want to hear what you want to hear, or do you want to hear the truth? And then I pause, because it's a lot of time that it takes for this line to sink in. And after some thinking, they say, we want to hear the truth, which means that you then have the right to speak your heart out. Then you slowly go into the discussion of what they have is not a happy situation. And I am truthful to the core. Sir, there is nothing that we can hide from a patient. Please understand that. Most of them, they know it. The family knows it even more than them at times. It's just that they are finding it difficult to let each other know that they know it. And you are the medium that they are using to convey it. So if it is a poor prognosis, it has to be shared with them. But sir, the other thing which I also tell all my patients, because I believe in hope as far as treatment is concerned, I have also believed that miracles do happen. So I tell them that anything that looks hopeless also will have something like a 90-10 or a 95-5 possibility. And you can hope and pray that you are in that 5. And that's how it works. Because at the end of the day, sir, we all know that medicine is not mathematics. And we've seen the best of patients getting the worst of results. And we've seen the worst of patients defying logic and outliving what we thought. So we have to go ahead, but you have to be pragmatic, truthful, and go ahead. So I convey it to them, sir. And usually when we convey, a lot of it is still unknown. You may see that the MRI is query infective, query metastatic. So you have to first tell them that you have to now undergo a biopsy. At that stage, you have to tell them the biopsy may be infection, it may be something else. When you say this word something else, they do understand it is cancer, but it is your duty to tell them something worse than infection. Then they will say, doctor, can it be cancer? You have to say yes. After which their next line will be, per doctor sahab, everything will still be well. Nah, that is what they want to hear from you. You say, let us work towards making it better. That's all. You cannot even at that time be non-factual to them. You have to keep telling them that, yes, we are working towards making it better. But you can never promise them that they will be fine. Because, sir, we have to handhold them going through that process of grief. And as you are probably aware, everybody with a situation like a metastatic disease of the spine has to go through those 5 stages of grief from denial to acceptance. So you have to go from denial to anger to bargaining to depression to acceptance. So this is the process where you have to work. So they will deny it on day one. They will accept it after a certain of period of time. But anger, bargaining, and depression are a part of the journey. So we have to initiate the journey and go through it.
Thank you. That's very clearly you explained that how we have to convey the poor prognosis.
The only thing is we also should add empathy. You know, that is what Dr.
Yeah,
Ram
I'm coming
told.
to that because
Yeah.
like you are a strong proponent of empathy. So now, how do
Before
you
that,
use-
before
Yeah.
that, can I just ask something, sir?
Yeah, please.
I've been faced with many situations where the family is aware of the condition, but they wouldn't want that to be disclosed in such open terms to the patient. So how do we handle that situation? That's what I always find it quite difficult. So how do you play around with the words and how do you make it easy on the patient? She's suffering or he's suffering, and how do we go about sorting out that situation?
Sir, it happens very commonly to me. I'm pushing myself.
Yes, this is your call, sir.
Sir, I see a lot of patients with multiple myeloma.
Yes.
Okay, where the patient's family knows that the patient has multiple myeloma, and I'm treating the patient jointly with a hematologist. Okay, the patient has not yet been conveyed that he has the big C or cancer, because that's the word they fear. We are fools if we believe that the patient does not know. But yes, we should still be with the patient and yet be with the family by telling the patient, आपकी जो बीमारी है उसकी treatment चल रही है. Hematologist is treating you for the medical part of it. I'm treating you for the mechanical part of it. My job is to see that the bone doesn't hurt, doesn't collapse, doesn't cause pressure on the nerves. But his job is equally important, and we are working on it together. You can now replace the word hematologist by the word oncologist if you're talking of metastatic disease. Unless at a particular stage, the patient confronts you with the word saying, "Doctor, do I have cancer?" I will then say yes, even if the family does not want it. But till that time, I can very well be with the family, because the family has told me, please don't tell him that he has cancer. But if the patient asks me and the family is right there, "Doctor, do I have cancer?" My answer is probably yes. That's where I am, because I cannot lie to the patient. But then that will not happen, because if he's going to ask me, he will probably ask the family before that.
Good. So coming to you, Vikas bhai, about the empathy. So like you have really conveyed the diagnosis to the patient. Now, in addition to telling that, how the empathy plays a role in that?
Sir, most of the doctors, we confuse ourselves between the words sympathy and empathy, right? And we commonly try to be sympathetic, Now, being sympathetic or showing sympathy sometimes can be taken in a very wrong connotation, and that's where there comes compassion and empathy. These are the two words which are very important, and this is what we as a human have to understand, because ultimately our medical field is a field where there is an establishment of a connect between two humans, and this is a psychological aspect of every human. It involves, as Chaddha sir rightly said, that there are all the stages, right from anger, denial, and the last stage comes an acceptance. In every that stage, you have to make the patient believe that what the journey that he is undergoing, you are with him and you understand his pain. See, understanding the pain of a person when he comes to you makes him more comfortable. And that's exactly empathy. That's not sympathy. So compassion is a stage before empathy, when empathy is where you make a person understand that his pain is very well understood by me as his treating doctor.
Okay. Then, Dr. Vikas bhai, you mentioned about the SDM, shared decision making. and putting that into the consent form, that's an informed consent. Time and again, a lot of patients, when you mention everything related to the complications, the likely complications, that this may happen, this may happen, this may happen, they ask you, and they really ask you a question that, sir, aisa hoga? Because like no one really like to read about the complications and to sign on that paper that these are the possibilities. So how do you respond to them, or how do you explain about the possibilities of complications?
This comes in the code of ethics, sir. As surgeons, we should be very true to the fact that we should do a complete disclosure of the entire process of surgery that the patient is going to undergo. So let it be treatment, let it be surgery. We are surgeons, right? So the entire process, every positives and every negatives possibly associated with that surgeries can be very well explained to the patient. First, always it comes in the process of shared decision making, right? Even the complications would also come. That's the stage when you would be talking to him about ye ho sakta hai, ye ho sakta hai. Because आपने जो सर्जिकली मिस्टेक्स करोगे वो नहीं बताना है, बट जो चीजें बॉडी में रिएक्शनरी हो सकती हैं, जो कॉम्प्लिकेशंस बॉडी में हो सकते हैं, विच इज नॉट इन द कंट्रोलेबल फैक्टर्स ऑफ अ सर्जन, वो तो आप हर चीज पेशेंट को समझा सकते हो, उसके रिलेटिव्स को समझा सकते हो, तो ही तो वो शेयर्ड डिसीजन मेकिंग करेगा ना। अगर आप उसे ये पिक्चर बताओगे कि नहीं आपको मैं नया जॉइंट डाल दूंगा और नया जॉइंट डालने के बाद आप अगले दिन चलने लग जाओगे एंड आपको 20-25 साल तक कुछ देखना नहीं पड़ेगा, राइट? नाउ you have not explained him so many things in this short thing that you have conveyed to the patient, you know. So there is a complete system that you will have to tell to the patient के ये क्यों कर रहे हैं हम, क्यों जॉइंट रिप्लेसमेंट सोच रहे हैं, जॉइंट रिप्लेसमेंट के ये पॉसिबिलिटीज हैं। आर्ग्यूमेंट्स कैन कम कि अगर हम ये सब समझाएंगे तो पेशेंट कभी सर्जरी के लिए रेडी नहीं होगा, लेकिन उस आर्ग्यूमेंट का काउंटर ये है कि अगर आप नहीं समझाओगे और आगे जाके अगर कभी कॉम्प्लिकेशंस हुए जिसमें आपने कंसेंट ली, जो पेशेंट बोलेगा कि हाँ मैंने तो साइन कर दिया सर, मैंने कुछ पढ़ा नहीं था, तब यू आर इन फॉर अ लीगल बैटल, राइट? सो इसलिए टू बी ऑन अ सेफर साइड, be clear in your conscience, be clear in your heart. As a surgeon, we are very well read, we are very well trained, we know what are the complications that could be anticipated, and we should always explain that to the patient and the relatives in a SDM as well as in this informed consent. And informed consent should be case to case. It should not be a common consent taken for everyone.
Good. So you explained about the possibility of complication. Dr. Ajith, now I would like to ask you a very direct question, that you have operated a patient for TBR nailing, and at 6 months you get X-ray and that shows that the fracture is not uniting. So possibility is that now you are going to stamp it as a non-union. So you want to, or you have to convey this to the patient that probably you need bone grafting or exchange nailing or removal of the screws and making dynamic. So how do you explain the complications to the patient? Because I find it very difficult to explain. So I really like to learn from you that what are your tricks and tips for that?
Sir, I think the scenario that you have given me is fairly straightforward. I think like Dr. Vikas said, at the outset, when you are taking the consent, all this is informed to the patient. I mean, we do tell them that, you know, nailing probably is the best option for this particular situation, for this particular fracture. However, there may be delayed union, there may be infection, or there may be frank non-union. We even tell them that, you know, if you don't address it in time, there may be implant breakage. So, yes, despite all this, if the complications do occur, we do have a very unhappy family and patient. But our defense is already there, like Dr. Vikas said, it is already there that we have explained to them and it is there. So the only problem comes if it's, let me probably put a surgical site infection. That may not be expected in a closed fracture. And I mean, maybe we do not counsel them as much about that issue, but it can happen. And that may be an uncomfortable situation for us to explain to the patient. I think that may be a better scenario maybe for me to explain. But I would tell them that, you know, at the outset, we tell them there is probably a 1% chance of infection. It's unlikely. If they ask me, have you had it, doctor? Many of the learned patients will ask you. The IT crowd will ask you, what is your incidence of infection, doctor? Or what is your incidence of non-union? Outright on your face, they will ask you. I think we'll have to give them some figures. And many a times we tell them, see, in the quoted literature, it is about maybe 1 to 2%. If it's an open fracture, it's a little higher. So, but most often in a closed fracture, like a few of my tibial plateaus have got infected, and that was an uncomfortable situation. And there were many questions as to where could the things have gone wrong, whether my OT sterility was not up to the mark, whether my surgical technique was not up to the mark. These questions were put across, and we'll have to tell them that, you know, it's very difficult to point out because every surgery, it's the same protocol. The same sterilization techniques happen, the same protocol is followed, the same antibiotic protocol is followed. So, but still there is, even in the West, a 1 to 2% chance of infection. So we sit and discuss, we explain to the patients and the relatives that this can happen. And it could be from your own, poor nutritional state or anemia or, something like that, that could have contributed. We discuss that, we interact, and we have to face the fact, and we tell them, it has happened. Now the way forward, what is the best way forward is that we go in, debride it or wash it out, and then put you on culture specific antibiotics, and then hope for the best, and hopefully it will be sorted out. And I think that's the best way that I find that I can be upfront and talk to them and say, yes, it has happened. The protocol that we follow is the same for everybody. People even ask me whether I have laminar flow theaters. They read up all this. They get information from the net. They get information from their relatives, and they will pointedly ask you whether you have had all these. So you'll have to be prepared, and you have to, in a very cool and calm manner, explain all these and tell them that it's my responsibility, that I will sort it out. And the best way is to go in right now and wash it out and put you on antibiotics. Yes, the stay will be increased, the cost will go up, but we'll make it as comfortable for you as possible.
Okay, good. Thank you. Dr. Chaddha, like what Dr. Ajith said is complications, which is always a possibility. But some complications are really very difficult for family and patient to accept. If I give you the example, in your case, a nerve root injury, which is really difficult for patient to accept, and it's not as reversible as Dr. Ajith said about the infection. So in that case, how do you explain that? That's the first thing. The second thing, there is always a blame game going on that probably you made a mistake. So what should be your stand at that particular time? So these are the 2 points I would really like to know from you.
Thank you, sir. I'm going to take both these questions. First, I'm taking it from the nerve root point of injury. Okay. I have, for the last 33 years, counseled my patients that there is a 1% chance of a nerve root injury in every surgery that I do. And it is made very clear to them preoperatively. And I say that this is not just literature, this is my personal history also, which means that they have to understand that I am a human being and I'm not God. Can it happen in my hand? Yes. Have you had it earlier? Yes. So that's how the discussion begins. And despite that, they have agreed to get operated by me. So one, sir, when a complication occurs, one is conveying to the patient, and second is conveying to yourself. So you will only forgive yourself if you have conveyed it to the patient in advance. I go back to a time when I couldn't forgive myself is because the first time when I had post-operative blindness in a patient. Sir, I had not heard of it till that time, sir. Thereafter, it is integral part of my consent. For the last 20 odd years, it's a part of my consent. But the first time it happened to me, I didn't know that such a thing existed, sir. That a patient could get up with post-operative monocular loss of vision on one side. And it hit me very hard. I've had it twice after that. I've had 3 patients in my life. But the second and the third were easier to handle for myself as well as for the patient. So first and foremost, you should know all that can go wrong. And you should convey it completely to the patient. So there was a time where paralytic ileus post-operatively used to hit me very hard because there was one place where I can't do anything. It is not under my control. Where my colleagues had to come and pacify me, they had to console me, be empathetic to me. Okay, Ram, it's nothing that you've done, but it's a part and parcel. But yes, it is something which should hurt you, sir. Please understand, it's only when you put yourself in the position of the patient that you will realize that paralytic ileus and staying in that ICU for 2 days excessively post-operatively and your bills going up to 1.5 times, it's very hard. So this is the way that you have to look at it, that even the worst of situations, you should have ideally conveyed it. God forbid it happens, like it happened to me when I got my blindness thing. Okay. I went up to the patient's family and said, this is very, very unusual. It has happened to me for the first time. I had shared with you all that has happened to me in my career, but this has not happened. I had even shared with you that there can be a post-operative death. This was a high cervical spine patient that I had operated. So they understood that it has hit me the first time. But yes, it is something which is difficult to get over. Nerve root injury is consented to and is a part of the consenting. Now coming to the second part, which is the one which you said, where people think that you made a mistake. Sir, you put a question to Dr. Ajith Kumar about 6 months post-operatively, you realize that the patient has non-union. Sir, it should have been at 6 weeks that you should have started realizing that he was going to go in for non-union. You should have not started appreciating your own x-rays or that 6 weeks. It is the time between 6 weeks and 6 months. If you have actually misinterpreted your own x-rays and kept saying that beautiful, we are going in the right direction, sir, you're doing harm. So the moment the surgery is over, look at the post-op x-rays as not your own, but somebody else's operation. That's the way I study it. You have to be very critical about what is happening and be truthful. If you think there is a delay at healing at 8 weeks or at 3 months, share it with the patient. I think that this is getting delayed. I think that you're not healing at the rate where you and I both expected. There may be treatable or non-treatable causes, we will treat them. One thing which I have learned to use, and I use it very commonly, and I do it in spine, and I request other people to do it in other subspecialties also. Sir, send them to the senior most person for a second opinion. Tell your patient, these are the 3 people who have huge experience. Please go to them. I believe they may have also had similar experiences in the past. And please ask them how it is handled. Sir, once they go to the senior people who have also had non-union, so there is nobody who in the world who has not had a non-union. Sir, then the person between the senior most and you will think twice to speak against you. Am I clear about what I'm saying, sir? If you send that person to a person who is the most experienced or the first top 2-3 people, so those top 2-3 people are there because they are gracious and grateful. They will send the patient back to you. Even if they don't, you know he's gone into better hands. However, That's the best way that I handle the situation. I learned it long back and I'm very happy doing it now. In fact, now if I get a second opinion from a colleague, I stand up and say, yes, this has happened in my hands in the past. This is how I have handled it. I think you're in the best of hands. Please go back. He will do a good job. So that is how confidence is built. Otherwise, sir, the patient is totally shattered if we keep speaking against each other. So I believe that the chance of taking the second opinion should be yours. You don't give one name, give 3 names. Go to any one of these 3-4 people. You choose. So that patient 90% will come back to you. So that's the way. So once you do that, then they will stop the blame game when they hear it that this can happen in somebody else's hands as well. That's the way I look at it, sir. Dr. Ajith, you're saying something?
Yes, yeah.
No, I just was about to say that whenever I have these problems, I make a note of it in the case sheet or in the outpatient chart. It is there. And all the points are there and my suggestions are there, maybe 1, 2, 3, whatever it is. And then I say, go take an opinion and come. And there are some devious patients, mind you, who will come back and twist the words of the other person. So if you have put it down there and the other person has also written it, and that sorts out most of the issues. So if at all I'm sending a patient to another person for an opinion, or if they are not happy with me and going elsewhere, it is documented. What I suggested, it is there. Whatever it is there. I think that is also as important as informed consent.
Yes.
Okay.
Every documentation.
Yes. Now, coming to a very important question, that our profession is basically a relation with the patient, and any relation is based on the trust. So I would like to ask all of you about, like, what do you do specifically to build trust? We start with Dr. Ajith. What do you do to build trust in your patient?
I think
Means like you are trustworthy.
I think the whole thing that we have been discussing all evening, I think that's probably part and parcel of, it encapsulates everything. Right from the time that you meet the patient, greet the patient, make them comfortable, that's where the whole process starts. And like Dr. Chaddha said, you be truthful, you be upfront, you tell them that this is the problem, this is my approach, this is what I suggest, or not suggest, this is what I think it is. Now, what you want to do, we can, discuss about it, or, basically letting them tell their story, listening to them, trying to make them feel that there is a person interested in their care. I think that's what makes them feel that you are trustworthy. Other than that, what they said, until recently, I was under the impression that your talking and your interaction, verbal is more important, but I've now realized that it is your body language, your eye contact, and the other things that are far more important. So, so it's a whole gamut of all these things. But I think eventually, if you make them realize that this is the problem, this is my approach to it, and if you want, you can have another, another discussion, or you can come back some other time if you have belief in me, or you can take another opinion and see what you think. So I think that's. Other than that, I think being truthful and honest, I think that's the bottom line. Dr. Chaddha mentioned that you be upfront, you be truthful at all times. That's it. I mean, over a period of years, I think they will realize, the word will spread, and they will realize, and they will come back to you. They will send you many more patients, in fact.
Yes, that's very important. Vikas bhai, what would you like to add on to what Dr. Ajith said about building or like developing a trust?
So, we
Trust and confidence are two different things.
let me tell you, sir, we are not like the Western society. In India, still, we inherit a very rich Indian culture, which is more than 5,000 years old. To most of our patients, doctors are next to God. See, we need to understand that. It is the doctors who need to understand that the patient has come to you because he has some sentiments. He knows about the success that you have as far as your surgical skills are concerned, but then he knows that he has some confidence in you. You have to see to it that that confidence, that honesty remains, in whatever communication, whatever service that you are going to deliver to that particular patient. Ultimately, what happens is that trust is also a process. It has not happened overnight. One fine day a patient or different person in a community will not have trust in you. You sit in a hospital, you have been serving the community locally for over years, and then you have delivered properly results, as well as your relationship, the doctor or a surgeon patient relationship has been fantastic. That enables you to build that trust. That is more important from my point of view, because confidentiality is there, honesty is there, the entire communication gamut is there, teamwork is there, because these are multiple things. But it is the patient's belief that अगर मुझे कुछ हुआ है तो मैं इनके पास जाऊंगा, वो मुझे ठीक कर देंगे, राइट? हाँ, उसकी वो बिलीफ को हम कितने हद तक साबित कर सकते हैं अपने आप को, उसे सच सच बताना है। लेकिन वो तो इसी बिलीफ के साथ आएगा, चाहे उसे कैंसर हो, चाहे उसे गैंग्रीन हो। लेकिन एक बार के लिए वो आपके पास आया कि सर मुझे गैंग्रीन हो रखा है, लेकिन क्या आप इसे बचा सकते हो? Right? That's the trust.
Okay, I did not clarify the two words, the confidence and the trust. I see these two words as Dr. Chaddha initially said about the hope, belief. Exactly. The same thing, the confidence and the trust, I look at slightly differently.
Yes.
The confidence is about your ability, your skill. That is confidence, that you have the best knowledge, you have the best skill to make him or her all right. That's about the confidence. The trust is this doctor is going to think best about me, or my interest is going to be the priority for this particular doctor. That's what we call it trust. Exactly. So how do you build trust in your patient, Dr. Ram?
I just build trust in my patient by being myself, sir. I am very clear about it, sir. I put myself in the position of the patient. I say what I would do if I was the patient. And I speak about what is my scope and my limitation. I say what I can do. He may ask me of multiple things that could be done in another way. Like there are very often things where he says, sir, can this be done minimally invasive? My answer is yes, it can. But when I do it, I don't think I shall do it. So then he says, what do you mean by that? I say, we are sitting on the ground floor in my clinic. This building has 14 floors. Can I jump off the 14th floor? So he said, no, sir, you should not. I said, exactly. So can it be done? Yes, but I cannot do it, sir, because I don't have a parachute which will open. So that's very clear. So it has to be made. You have to be very clear what is your scope. So that's where we work, sir. If you start branding or marketing yourself as something that you are not, that is where the trouble comes in, sir. So do what you're capable of. Tell them the scope of your procedure or of your line of treatment, and still tell them that things may still not work out exactly the way you want it. I use a lot of very simple examples, sir. I'm a Punjabi at heart, so most of my examples are related to food, sir. So a lot of my examples are related to 100 aloo ka parathas that my mother makes. That is my commonest example, sir. I call people for dinner. My mother makes 100 aloo ka parathas. 95 of my friends go home and call me up and say, this is the best aloo ka paratha they have ever eaten. 4 of them call up and say, my mother makes it better. One fellow does not call up. After 3 weeks, I call him up. He says, do you know I had food poisoning and I was in hospital after that. My mother made the same aloo ka paratha and gave it to all of them. That is enough to explain everything to them, sir, from good result to not very good result to complication. Very clear about it. My 95-4-1 works that way every time. And everybody understands. There is no complication. So you have to be very simple. होता है sir, सबसे होता है. कुछ नहीं कर सकता है. As long as your intent is to feed them a good aloo ka paratha, that's all that matters.
Okay, thank you very much. While discussing on these important points, 90 minutes passed away very, very smoothly and without any knowledge. So I must thank all of you, Dr. Chaddha, Dr. Ajith, and Dr. Vikas, for sharing your experience and your techniques with us. And I would request Dr. Ramesh Sen to say something about this session. And should we continue in future, and what should be the direction for future such webinars? Over to you, sir.
Thank you. Definitely, in day-to-day practice, these are the most important and most technically, maybe we can say in the day of today, difficult also. They are not very easy to imbibe into the practice for many reasons. But important means important, and our learning, that exactly is our perception also, that it just like we have a lot of time spending on courses, on special seminars to learn those surgical skills. Equally important, we have to spend our time in learning these soft skills. It's not like that they can't be learned. Yes, it may be difficult to change a practice in a day to become so ideal, but right now it is not only ideal, it is the essential also. So I think with these kind of a seminars spaced appropriately and with all the best experts across, we are likely to gain a lot. And that exactly was our presidential theme, that we must start thinking beyond surgical skills. And this is an essential tool. So I really thank the faculty to have given such a positive thing and a big positive note to this session. And I do hope people will make use of all that advice which has been shared by the experts. And I hope we become better surgeons with the skills as well as with the soft skills. Thank you.
Yeah. And Naveen, your comments and feedback.
It is a very useful topic, and there are comments that it's a very, very good and useful topic. Dr. Atul has written already that I could not join, but it's a very useful topic, and he has shared the photographs also. And I think it should continue. It can be a long series up to 100 because it's a good topic, and it's requirement, it's the time demand of the time also. So it should continue.
What I feel is what we discussed today is a theory.
Theory, yeah.
But we should also have a practical training for communication. So Dr. Chaddha and Dr. Vikas Bhai, please think on that. Probably that will give us a better output about such workshops.
Here, storytelling will work, I think, probably.
Yeah.
That will give a practical life experience, examples where you can exactly say how you have conveyed and how it has solved the problem.
But so we have all remembered the Dr. Chaddha's 95, 4 and 1 parathas.
Aloo paratha, yeah. So okay. same thing. I tell in a different language. I say that how many of your family member has gone to Amarnath Yatra? They ask for the surgical risk and anesthesia risk. Then I tell them how many of all have come back or not. They say no. Few people in my neighborhood and never came from the Amarnath Yatra. So it is same thing like Amarnath Yatra.
Right. So thank you very much once again, everyone. And please give us your feedback. And we would definitely like to do more and more such webinars. Bye-bye and good night.
Thank you.
Thank you, sir.
Yeah,
thank you for having us.
Thank you.
Bye-bye.
Good night. Good night.
Good night. Good night.
Ashok ji, you can stop the live streaming and recording.